Hello everyone. Welcome to the most awaiting emerging MEDTALK. I know you are going to stick around as this series will be loaded with 100% simplified practical approach that are guaranteed not only to bring your attention but also make the topic understandable. And lastly, the 10 important points, the tips particularly, will be the game changer for your confidence. So, this series of X-ray, that is reflection, will be helpful for all my colleagues, then PGs, interns, all my MBBS, BMS, BHMS, BDS, BPTH, these all nursing, BPMT, all paramedical and technical students. So, this is Professor Dr. Prashant Busari welcomes you on this emerging MEDTALK. Topic of discussion is practical approach to chest X-ray, that is chest radiograph, and how the anatomical landmarks reflect on the chest. We will discuss step by step. So this is the chest X-ray. So we'll discuss now practical approach. So here is the chest X-ray, that is side is right side. So this is right side, and the projection is posterior-anterior. The X-ray beam passes from the patient posteriorly and the cassette is placed in front of the patient. So posterior-anterior projection, that is PA view. Then another mnemonic, it will be the eyes. So I, that is inspiration. So proper inspiration, so anteriorly around 5 to 6 ribs will be present, anterior ends above the diaphragm, and 8 to 10 posterior ends will be above the diaphragm. C, well centered, that is the spinous process equidistant from the medial ends of the clavicle. Then the exposure, so proper exposure, so above 4 thoracic vertebrae where is seen clearly and below will be barely visible. So this is in short eyes. Then we'll start the reading this chest X-ray under this what we can say the ABCD approach. A for airways, B for bone, C for cardiac shadow, D for diaphragm, and E for effective lung field. Before that, very important two densities are important, that is radiolucent, that is black radiolucent, and particularly related to lung, and radio opaque, that is related to white, that is bone, metals, or the some soft tissues. So approach is ABCD. So here is the, that is A, airway, that related to trachea. So here we can see these translucent shadow in the midline. So that is nothing but of trachea. So this is translucent shadow, midline tubular structure in the upper part of the chest, and it bifurcates into right principal bronchus and left principal bronchus at the level of the around fourth lower border of the thoracic vertebra. That angle of bifurcation we called it as carina. That is nothing but the bottom of the sheep, and angle is around 40 to 80 degrees. If it is more than 100 degree, there may be the left atrial enlargement. So we will see this airway here. So we can compare on the CT image and we can easily see the trachea. This is right principal bronchus, left principal bronchus, and the carina. So it is midline and around 10 to 12 centimeter in the neonate, particular newborn. It may be around 4 to 5 centimeter, and if it may pull opposite, here is the pleural effusion, it pulled opposite side in the pleural effusion and it is shifted towards the side that is in the volume loss, that is collapse of the lung. So this is airway. Second will be the bones. Second will be, so bones particularly. So here we can see the on east side the clavicle, the horizontal long bone, that is horizontal place long bone on each side, and this is medial end. Here is the what we can say the lateral end of the clavicle, and medial end, both they are equidistant from the spinous process of the thoracic vertebra, and it medial end articulates with the sternum to form the sternoclavicular joint, which is of the saddle variety. This is collarbone. Then next will be will discuss about this shoulder blade, that is scapula. So here having this medial border, lateral border, then superior border. Here is a spinous process. Here is a inferior angle, then superior angle, and at laterally the glenoid cavity, it articulates with the, that is head of the humerus to form the shoulder joint. Now very important, that is counting of ribs having anterior ends and the posterior ends. So we can see very well here the first rib. So here will be the first rib, and very important, that point of importance is anterior end of the first rib always lie just below the clavicle. So this is anterior end of the first rib. Here is the anterior end of the second rib. Here will be the anterior end of the third rib. Here will be the anterior end of fourth rib line. So these are the anterior ends, and the and medially it articulates with these thoracic vertebra. So there these will be the posterior end. So here will be the fourth, fifth, sixth, seventh, eighth, ninth, 10th. These are the posterior ends of the ribs. Anterior ends, these looks like interrupted because these are articulate with the sternum through costal cartilage, and costal cartilage not seen clearly on the X-ray. So this is big difference. And also we will see the thoracic vertebra. So upper fourth thoracic very clearly, and lower will be the that barely visible. So these all will be the thoracic vertebra, around we can say the 12 thoracic vertebra. So we can compare these bones in this very simplified image. So we can see here the on each side these are the clavicle, then here will be the shoulder blade, these will be the which ends, anterior. So this is important, these are the anterior ends, and on this medial side will be the what, these will be the posterior ends. So these are the anterior ends, and these will be posterior ends, and all these will be 12 thoracic vertebra. So this is very simple. Now why we are discussing these bones? So very simple here. Here is we can say break in the cortical continuity of the clavicle. So there is a cortical, we can say the fracture of the clavicle, and here also we can see there is a break in continuity of the ribs. So there is a fracture ribs. So after the B, we'll discuss third, that is also important, that is cardiac shadow, that is C. So the here important, the heart situated within the mediastinum between right and left lungs, and we can see here there are the two borders, right cardiac border and the left cardiac border. So here major portion of the right cardiac border is formed by right atrium, is formed by right, and above some portion by the superior vena cava, and below by the some portion by inferior vena cava. So main by the right atrium, and on the left side very important prominence or the projection we can see at this level is nothing but aortic knuckle. So this is what aortic knuckle. Aortic knob. So this projection arises from the when the arch of aorta runs posterolaterally to become the descending thoracic aorta. At that point, it makes a projection of the prominence on the X-ray. This is what we call it as aortic knuckle or aortic knob. Just below will be here the what we can see the main pulmonary trunk with the branch left pulmonary artery, some portion by the left atrial appendage, and major portion by the what, left ventricle. So left cardiac border mainly contributed by the left ventricle, above by the left atrial appendage, then the main pulmonary artery with left this left branch, and above that projection is the aortic knuckle. Now here is important is cardiothoracic ratio. So that determines the size of the heart. So here when we draw the vertical line along this spinous process, so maximum diameter on the right side as a, maximum diameter on the left side as a B, and this maximum transfer diameter of the thorax as C. Then you know A plus B is always half that of the C. So half the diameter of the thorax. If the diameter of the thorax is 30 centimeter, then the diameter of cardiac will be around 15 to 16 centimeter, that is 50 to 55 percentage. So this is cardiothoracic ratio. So we can compare this cardiac shadow very clearly on this CT image. So we can see here on this right side, major contribution right atrium above superior vena cava, below some portion by the inferior vena cava. Then here is major portion on the left side will be the left ventricle. Here will be the left atrial appendage. Then main pulmonary trunk. Then above will be the aortic knuckle or the aortic knob. So this very simplified, and the cardiothoracic ratio is 50 to 55% percentage, and if it increases, the condition is called as cardiomegaly. So this is why we are discussing the normal anatomy. So after this cardiac shadow, we will discuss the diaphragm. So here will be the right hemidiaphragm and here will be the left hemidiaphragm. So these are dome shape, these are not straight, and it makes an acute angle with the ribs or the lateral, we can say the thoracic wall, and on each side these angles called as right CP angle and left CP costophrenic angle. So these are around 30 degrees acute. It also makes angles with this right cardiac border and left cardiac border. So these angles, these cardiophrenic angles are also acute. Then we can see the here, this is a fundic shadow just below the left dome of diaphragm, and this is normally situated. If it is on the right side, then the condition abnormal, that is maybe due to perforation. So now we can this correlate simultaneously with the CT image. So this is right hemidiaphragm, the left hemidiaphragm making angle with the lateral wall forming the costophrenic, and here as a cardiophrenic angles. So very simplified, and these angles will be obliterated. Here this angle of the on this left side obliterated in the condition called as pleural effusion, and here also we can see there is no cardiophrenic angle seen properly. The condition is due to maybe due to pericardial effusion. So this is why we are continuously discussing the normal anatomy. Then after this what we can say diaphragm, we will see the effective lung field. So lung parenchyma or the lung field. So these are right lung, and here is the left lung, and here is the apex, here is the base of the lungs, and we can see normally some these tubular reticular on each side the radio opaque and shadows. These are normally present due to the bronchiovascular markings, and this radiologically lung divided into the three zones. So when we draw the horizontal line passing from the anterior ends of the second rib and anterior ends of the fourth rib, these divide into the upper, middle and lower lung zones. So above the second anterior rib is the upper, in between middle and below the fourth anterior rib line will be the lower lung zone. So this is very simplified, and there is no clear cut lucent shadow see here because it are having the bronchiovascular marking. So this is very important because this loss in the condition called as this pneumothorax. Then in this we will also see hilum, that is right hilum and left hilum. So this is right hilum on this side, and here is on this left hilum. So right and left, left hilum is always at a higher level than the right hilum. And um, so here we have seen these we can correlate here simultaneously. This is right lung, left lung, and having the three zones divided, and having these are the very clearly seen the bronchiovascular markings, which are seen clearly in the lower zone, particularly on the posterior anterior view. So we know, but if any abnormal opacities, then we should know the conditions. So here we can say this radiopaque opacity defined in the right mid-lung zone. So it may be due to the consolidation if infective pneumonia. And here there is a volume loss on the right side and shifting of the trachea and mediastinum towards right side. So here is the condition, why what we call as collapse of the lung. So how this we have discussed. So this chest X-ray under these five headings: A, B, C, D, E pattern. A, airway; B, bones; C, cardiac shadow; D, diaphragm; E, effective lung fill. So here is how we'll see the normal X-ray here particularly. So there is this chest X-ray. If it is normal, how you to this report? So we'll see the chest X-ray. This is a posterior anterior view, and here projection technique is posterior anterior projection. Findings: both these lung fields are equally translucent. Then both the costophrenic and cardiophrenic angles are clear. Then the no hilar or mediastinal, we can say the mass. Then both domes of diaphragm in normal contour and position. Then we can say the cardiac outline is normal, and also no obvious skeletal, you can say the abnormality or any fracture. So very simple. The impression will be no significant abnormality seen at present X-ray. So very simple, the normal X-ray. Then now if we know the normal, so how we can have some in brief the crux or the tips of these various points. So very important, the anterior end of the first rib always lies below just below the clavicle. Then right dome of diaphragm is always 1.5 to 2.5 centimeter above the left dome of diaphragm. Then left hilum is always at a higher level, around 1.5 to 2 centimeter than the, we can say, right hilum. Then this radiologically lung having three zones: upper, middle, and lower, and anatomically is different. And also there are the bronchiovascular markings normally present. So trachea bifurcates at the level of lower body of the fourth thoracic vertebra into right and left principal bronchus. That bifurcation is called as carina. Then clavicle plays somewhat obliquely in posterior anterior view and plays somewhat transversely, horizontally straight in anterior posterior view. Then costal cartilage not visible on the X-ray. So the anterior ends, they are not continuous with the sternum. They looks as interrupted. Then we can see here this fundic gas bubble seen just below the left dome of diaphragm. Normally, if it is placed, well, we can say below the right dome of diaphragm, it is abnormal presentation. It may be due to perforation. And we can see the costophrenic angles, they are obliterated, not seen, obscured in the condition called as pleural effusion, where the fluid accumulates within the pleural cavity, and cardiophrenic angle obliterated, obscured in this pericardial effusion. And lastly, when air trapped in the pleural cavity, we call it as pneumothorax. How to differentiate? Normally, the lung, we can see the bronchiovascular markings, but here the bronchomuscular marking, they are totally absent. It looks all that translucent, and that may be due to the road traffic accident. On 10 views of the chest X-ray, very most common is the posterior anterior view. Routinely we are doing, that is 90 to 95%, then the anterior posterior, then lateral, and other views. So first view is the posterior anterior view. So it is the standard frontal projection, and it is taken in the full inspiration, and the X-ray it passes from posterior to anterior side, and the film cassette is placed on the in front of the patient. So this is PA view. So we can see here, this is X-ray tube, and how this X-ray passes from this posterior to anterior side, and this cassette is placed in front of the patient. So this is posterior anterior view, where the we can say obliquely place these clavicles, obliquely place ribs, and also the proper size of the heart we can this measure. And also we can see these scapulae place out of most of the part out of the field. So very this common, this is a posterior anterior view. Then anterior posterior view, where the beam or the X-ray passes from anterior to posterior side, where the intubated sick patient particularly standing is difficult. So in that condition, anterior posterior view, we can see here this is X-ray tube, and how this X-ray passes from anterior to posterior side, and cassette is placed behind the patient. So here we can see transversely straight clavicles, then transversely horizontal running these ribs also. Then there is a magnified appearance of the mediastinum, that is heart, and also we can see here particularly the bronchovascular markings equally distributed on this whole of the lung parenchyma. So next, after this anterior posterior, is this third is lateral view, where the particularly we can see the retrosternal retrocardiac areas not seen clearly on PA and AP view, can be seen clearly on these we can see lateral view. So here we can see. So this is the chest X-ray lateral view. Then next will be the lateral decubitus. Very small amount of pleural fluid, pleural effusion can't be seen on this PA, AP or lateral view. So the patient we can see is lying either in left lateral or the right lateral, and very small amount of fluid can be measured in lateral decubitus condition. Then expiratory film, particularly important for the suspected pneumothorax, or we can say the ear trapping due to inhaled foreign bodies. So this is expiratory film. Then lordotic, particularly the area behind the clavicles not seen clearly in the posterior anterior view. So special view for that is lordotic view we can see, and the particular lung apices behind the clavicles can be visualized clearly. Then right or left anterior oblique, for most of the oblique positions, and most of the we can see the ribs can be visualized here, and there may be a posterior oblique also. Typical ribs view, where the most or the part of the ribs we can see throughout its extent, and here particular fractures or some bony pathology can be detected in this view. And then next, sternum lateral view and the sternum oblique view, where the pathology related to sternum, either related to the fractures or the these bony tumors, can be detected in these views. Topic is on chest X-ray, difference between posterior anterior and anterior posterior view. So here we can have very commonly posterior anterior view. It is a normal standard projection, and it is in the full inspiration, and it is taken in the standing position, and X-ray beam traverses from posterior to anterior side. So this is X-ray tube, and we can see how this X-ray passes from posterior to anterior side, and film cassette is placed in front of the patient. So this is posterior anterior view. We can see this is posterior anterior view. Then second is anterior posterior view. It is opposite, where the direction of X-rays is from anterior to posterior side, and where particularly in the sick intubated patient, it difficult for the standing. So in this condition, anterior posterior view we do. So here is X-ray tube, and we can see how the X-ray beam ray passes from anterior to posterior side, and cassette is placed behind the patient. So this is where the this clavicle plays horizontally, anterior posterior view. So 10 different tips or the different points we can see. So here is this the posterior anterior view. So position of patient, X-ray passes from posterior to anterior, here from anterior to posterior side. Distance is around 6 feet in between patient and the tube. Here distance is 4 feet. So next, clavicle. In this posterior anterior, it is somewhat S-shaped and obliquely placed. In this AP view, there is a straight horizontally placed, we can say, the clavicle. Scapulae in the posterior anterior, it is out of the field, and in this anterior posterior, it is most of the lung field may occupy. Then the ribs, particularly, it is placed somewhat obliquely. So we can say this obliquely place these ribs, and in this AP view, this is placed horizontally. Then the vertebral bodies up to the four thoracic, these thoracic vertebra clearly seen, and below will be the barely visible. Here all they are visible on this AP view. Then mediastinum and heart, it on this and PA view, it is normally appears as it is. We can measure and decide the cardiomegaly also, but in the AP view there is a, we can see the appears enlarged or magnified on this AP view. So the bronchiovascular markings, particularly in the PA, it is more common in the lower lung zones, and in anterior posterior view, it is distributed throughout the equally in the whole lung zone. Then fundus of the stomach position, in the PA view, it is normally situated just below the left dome of diaphragm. It is erect position, standard position, and but in the anterior posterior view, we can't see the this position of the gas shadow. Then position of the, we can say, the lung field or lung parenchyma, it is well defined, but in the AP view it is less well defined because of the this scapula also, and magnified image of the these, we can see the this heart or the mediastinum also. Then diaphragm, in the PA view it is at around 5 to 6 intercostal space or the rib, and in on the AP view it is elevated. So most common we are doing is the posterior anterior view, and in sick or intubated patients is the anterior posterior view or the abnormal conditions of the chest X-ray. So we already know the various normal X-rays, how it represent. Here is the, we can see the this midline translucent trachea. Then this is right lung. Here is the left lung. Here is a cardiac shadow. These are the clavicles bones. These are the scapulae. Then we can see the right dome of diaphragm, left hemidiaphragm, then the right cardiac border, left cardiac border, and these are the bronchiovascular normal markings, and having radiologically lung having 3 zones. So if some lucencies and opacities having its different patterns, so we'll discuss how it appears on the abnormal chest X-ray. So here we can see the opacity on this first, second, and also we can have on the fourth part, and the some lucency without the bronchiovascular markings. So which condition we call? So these we will see. So abnormal these conditions. So very common is the pleural effusion, where this fluid, it accumulates within the pleural cavity, and in this we can see there is a obscure or the left costophrenic angle is not seen clearly, obscure in condition of the pleural effusion with the homogeneous, now we can say the radio opacity, and also there is a little shift of this trachea or the mediastinum towards the opposite side. Then pulmonary consolidation, where it is due to infection, then we call it as this pneumonia, and we can see here this radio opacity in the right middle lung zones, and these, if they particularly the alveoli, they are replaced by the fluid or these infective foci, and the pneumonia may be lobar or the interstitial or the bronchopneumonia, and having various patterns. So here is pulmonary tuberculosis, in particular 60s to 70s in the India, very common, and in the right upper lung zone, but when it the spread is hematogenous, then the condition is called as miliary tuberculosis, where the appearance is diffuse nodular appearance. Then pneumothorax, we know the lucency in the lung, particularly having the bronchomuscular markings, but when there is a clear-cut translucency without the bronchiovascular markings, and it is after the trauma or the road traffic accident where the air trap in the pleural cavity, then the condition is called as pneumothorax. Then we know the cardiothoracic ratio is 50 to 55%, and if it is more than, the condition is called as cardiomegaly. Then aortic aneurysm, particularly the dilation of the aortic knob at the level or aortic knuckle, and there is what we can say enlargement of the aortic knob and displacement of the trachea towards the affected side, also opposite side, the condition is called as aortic aneurysm. Then the emphysema, particularly in old age, where the bilateral, we can say the hyperlucent lungs, and the domes also, they are looking like flattened, they are not dome shape, and as ribs they should be oblique, but here looking, we can say horizontal, and there is a narrow mediastinum in this condition of emphysema. Then collapsed lung, where there is volume loss, very important, with volume loss here in the right lung with the, we can say, pulling of that trachea or the mediastinum towards the affected side. This is a very peculiarity of the collapsed lung. And there is the loss of cortical continuity, there is a rib fracture here, and also there is a clavicular fracture in these conditions. Then we know 12 ribs arises from the thoracic vertebra. If extra rib arises from the 7th cervical vertebra, the condition is called as cervical rib, where the very small extra rib arises from the 7th cervical vertebra. Then the bronchogenic carcinoma or the lung mass, where we can say particular old age, smoking history, and we can say there is abnormal ill-defined opacities involving some part, or it may involve most of the lung parenchyma, that may be the condition due to metastasis. So here we can say the lung mass and not responding to the treatment. So there is dextrocardia, where we know normally the heart major portion is placed on the left side. If it is placed on the right side, the condition is called as dextrocardia. Here we can see particularly, and it may be the part of situs inversus, and it may be involved in the syndrome called as Curtagner syndrome, where there is a dextrocardia, then there is a stereocilia, infertility, there is infections, and the condition is the Curtagner syndrome. So this is what the different, what we can say, the abnormal or the pathological conditions of these chest X-ray. So if you like, if any queries, if any problems, suggestions, please add in the comment box, and we have different X-rays series on this of body on this under the series reflection. So having various videos, so please subscribe for the further videos. So this is all about what we can say for the today's discussion, that is abnormal chest X-ray. Thank you.